So next, we'll hear from Dr. Alessandro De Luca, who comes to us from Italy, and he will talk about prenatal RASopathies, the diagnostic yield, genotype-phenotype correlations, and recommendations for testing. So good luck in light of what we just heard.
Okay. This.
Yeah?
Yeah.
Is it working?
Yes. So in this 15 minutes talk, I will talk to you about the prenatal features of RASopathies. Then I will present some results of our work on diagnostic yields and preliminary results on genotype-phenotype correlations in prenatal RASopathies. And then in the frame of updating the guidelines for management of Noonan syndrome-related disorders, I will provide with you some recommendations for testing in RASopathies. I have no conflict of interest to disclose. No? So, prenatal diagnosis of RASopathy can be very challenging, mostly because of two main reasons. Their variable expressivity and because of the non-specific prenatal presentation. But in the last years, many suggestive ultrasound features have been defined. These include mainly ultrasound features of lymphatic dysplasia, including increase in NT, which is an enlargement of soft tissue in the back of the neck, which is present in the first trimester. A similar feature is observed at the second trimester and is called increased nuchal fold. In the first trimester, you can find in 10-15% of fetuses with Noonan syndrome distended jugular lymphatic sacs, which is an enlargement of the ducts that are positioned bilaterally to the neck. Then cystic hygroma can be found in 30% of fetuses with RASopathies, with Noonan syndrome. It is an abnormal accumulation of fluid posteriorly to the neck. And then there is, we have already heard about it, fetal eye drops, which is an abnormal accumulation of fluids in 2 or more fetal compartments. It's are very frequent also effusions in the thoracic area and the abdominal area, pleural effusions, hydrothorax, and ascites. Cardiac abnormalities are very common, 30-40%. They include the specific structural abnormalities, pulmonary stenosis, hypertrophic cardiomyopathy, and also fetal arrhythmia. Other associated findings is polydramnios, which is an increased amniotic volume of amniotic fluid, specific renal abnormalities, microsomia, we have heard about it, some mild central nervous system abnormalities like mild ventriculomegaly and shortening of long bones. Not too much. So, in the presence of a suggestive prenatal ultrasound findings, depending on the study, the diagnostic yield that you can reach is around between 6% to 20%. But it's very important to define which are the specific prenatal features that can be considered the most suggestive for a RASopathy. And if one suggestive finding is enough to ask for a prenatal testing, or you need to have a combination of finding. And we don't know very much about the mutation spectrum of prenatal RASopathies, which are the genes that we should test. So to answer to this question, we carried together with another group in Canada, in Montreal, Saint Justine Hospital. We carried out a multi-center study. We collected 352 cases, and the inclusion criteria in the study was absence of chromosomal abnormalities because they go in differential diagnosis with RASopathies, prenatal level. Fetus is referred for prenatal genetics clinics because it's suggestive prenatal RASopathy finding. For 312 of these patients, we had complete pregnancy longitudinal longitudinal data from first to third trimester, as well the outcome. A RASopathy panel analyzed, including at least the most important genes. I think that the minimum was 11 genes. So the Canadian cohort included also a postnatal cohort of 25 children with molecularly confirmed diagnosed RASopathy with available prenatal data. And we compared the mutation, prenatal mutation spectrum with the NS Euronet database, which includes more than 4,000 cases, and the internal institutional database of my laboratory. So the increase in NT and cystic hygroma were the most common indications for testing, respectively with 74 and 58% of the cases. We observed that some suggestive prenatal findings were more common in the prenatal mutation positive group, respecting, no, Stiffy, okay. I don't touch it anymore. Okay, so very much more common in the positive group than in the negative group. This included increase in F, eye drops, thoracic effusion, congenital defects including HCM, hypertrophic cardiomyopathy, polydramnios abnormalities. One important thing that we observed is that the mean NT, the thickness of the NT, was higher, significantly higher, 6.4 millimeters in the positive groups, respecting to the negative group, 4.8 millimeters. The global diagnostic yield was 15%. We observed that increase in NT, the diagnostic yield increased with the increasing of the thickness and was 20% for NT above 6 millimeters. So the detection rate for cystic hygroma was 16%, but this is very important, increased with if the cystic hygroma persisted in second trimester, and increased also if cystic hygroma was associated with another finding, 28%. Then we observed that certain evocative findings reached the very high diagnostic yield, like increase in F, 25%, eye drops, 33%, thoracic effusions, 41%, and congenital defects, in particular, if you have HCM, almost 70%. And we had 6 cases with HCM combined with another congenital defects, and they were all related to RASopathy mutations. Also, if you show polydramnios and renal abnormalities in combination with another prenatal findings, the diagnostic yield was very high. And we observed that with the increasing of the number of the suggestive findings, you increase the diagnostic yield, starting from if you have a unique finding to 3% to 9% to 18% if you have 2 or more findings. So the highest diagnostic yields were obtained for hypertrophic cardiomyopathy combined with or without another defect, thoracic effusions, eye drops, cystic hygroma in association with another evocative findings, congenital defects, and persistent cystic hygroma. So the suggestion is that after you do CMA, like chromosomal microarray analysis, RASopathy testing should be offered if any prenatal ultrasound finding of this lymphatic dysplasias of a cardiopathy is present, also when it's present alone, because it was 9%. It may be not worth it when it is isolated increase in NT, because the efficiency is very low, detection rate is 1%, but may be considered when you have an increase in NT above 6 millimeters. Polydramnios, renal abnormalities, microsomia, mild ventriculomegaly, and short log bones, they significantly increase diagnostic yield, but probably they are not. They are too commonly encountered in a prenatal setting, and diagnostic yields presumed to be very low, and so it's not justified maybe an invasive prenatal RASopathy testing. In regard of the mutation spectrum, we identified 65 mutations, variants, 52 were pathogenic or likely pathogenic, 13 were variants of unclassified significance. In one patient, we identified a compounded heterozygous for LZTR1 mutation, autosomal recessive Noonan syndrome. In one patient, we identified 2 two mutations in two different genes, one in NF1 and one in PTBN11. The mutation spectrum included encompassed 11 genes. The most commonly mutated genes were PTBN11, RIT1, RAF1, HRAS, and LZTR1. The mutation spectrum was very different from the mutation spectrum that we find in postnatal RASopathies, with less mutations in PTBN11 and more mutations affecting RIT1, RAF1, HRAS, and LZTR1. SOS1 had the highest number of variant of unclassified significance. When we look at the genotype-phenotype correlations, we observed that severe manifestation of lymphatic dysplasias like eye drops or thoracic effusions were more commonly associated to mutations in RIT1, RAF1, HRAS, but also some cases of LZTR1, and also in cardiopathies. Mutations in PTBN11 in SOS1 were a few mutations were associated also to severe manifestations of lymphatic dysplasias, but generally mutations in PTBN11, KRAS, and SOS1 were associated with a milder presentation characterized by single suggestive findings. In fact, PTBN11, SOS1, and KRAS, when we analyzed the postnatal cohort with available prenatal findings, we observed that 50% of the fetuses, they didn't show any suggestive findings, so less penetrance. We observed also some PTBN11 mutations that are associated with a milder prenatal phenotype, like the SAN 308 aspartate or threonine 468 methionine that we have seen before. But we also observed some PTBN11 variants, variactivating variants that at postnatal level are associated with very severe form of Noonan syndrome associated with GMML, that we observed that they have very high frequency, 14% compared to the postnatal spectrum, which is 2%, in two fetuses with fetal eye drops and lymphatic abnormalities and adverse clinical outcome. And we never observed, for example, these mutations affecting this hotspot in SOS1, which is the most common mutation seen at postnatal level. HRAS mutations were always associated with very severe prenatal presentations with severe forms of fetal eye drops. The mutation spectrum was completely different from the one that you see at postnatal level. The most common mutations, 80% of Costello syndrome, we never found it. But we found a mutation, this one, glutamine 61 arginine, that is never encountered at the germinal level, but is found only at somatic state in Schimmelpenning syndrome or cancer. And it was a mutation associated with severe fetal eye drops and spontaneous fetal demise. We observed, we had 6 cases, and 4 cases harbored these 2 mutations that are present only in 2% of the postnatal level, and are associated with the high prevalence HCM and arrhythmia. We observed it in 4 out of 6 of our fetuses with HRAS mutations, more than 60%. LZTR1, RIT1, and RAF1 mutations were associated very much with severe phenotypes. LZTR1 and RAF1 more with fetal like eye drops and lymphatic dysplasia, where the RIT1 with a very high incidence of hypertrophic cardiomyopathy. We didn't observe we only observed 1 BRAF mutation, so very few mutations associated with CFC. There is a more recent paper that described, however, 3 cases with recessive Noonan syndrome, and 2 of whom they had hypertrophic cardiomyopathies in the 3rd trimester. So We also related the timing of the prenatal manifestations with the severity of the postnatal phenotype. What we observed is that patients with the most severe phenotype, they have they are more frequently diagnosed in the prenatal period, whether patients showing milder presentation, they are very rarely diagnosed at prenatal level. So here I will present just some work that we have done together with in an international effort in the last years to provide updated guidelines for the management of Noonan syndrome spectrum disorders. This work was coordinated by Emma Burkitt-Wright, who is here from United Kingdom, Marco Tartaglia, Italy, Alain Verlot, France, and Martin Zenke, Germany, encompassed 12 different areas. I was involved in I will present the recommendations, preliminary recommendations for the management of Noonan syndrome spectrum disorder in prenatal phase. The working group included 6 professionals, 2 from Italy, 2 from the Netherlands, and 2 from Canada. We used the PRISMA method to select the literature based on using general terms like RASopathies, RASopathy-like syndromes, and the genes mutated in RASopathies, and specific terms like prenatal diagnosis and prenatal RASopathy-related features. We started from more than 100 records, and after excluding all papers that were not related, functional studies, animal studies, studies on Costello syndrome or NF1 that have their own guidelines, we remained with 33 papers. After a series of meetings, we proposed 10 key points, including prenatal findings, molecular testing, genetic counseling, pregnancy management, and pregnant women with Noonan syndrome spectrum disorders. In April, actually, 2025, we met in Paris. We reevaluated this and finalized these proposed recommendations. I just want to present part of our work on the prenatal findings. So no individual prenatal finding is pathognomonic of Noonan syndrome spectrum disorders. The evocative findings include most of those that I have presented before. I want to say only a few words on the increased nuchal fold, so isolated increased nuchal translucency or nuchal fold can be used, but it must be above 5 millimeters. Persistency of nuchal edema or eye drops are very important as well. Polyhydramnios prenatal renal abnormalities and fetal microsomia band findings. These are supporting findings, and they're used to be when they are combined with other features. And molecular testing should encompass all the genes and plus minus those in differential diagnosis. So thank you very much. This is to acknowledge. Yeah.
Thank you for this comprehensive overview. Do we have any questions? Dr. Gelb?
Nice talk, Alessandro. Do you have experience yet with NIPT findings and conversions and features for that? Because we're seeing that increasingly in the US, where people are, older women are getting that even as a screening test and coming up positive for RASopathies.
Actually, yes. Sometimes we have to work on confirming the results on amniocentesis. My opinion is that still it's better to use the invasive prenatal diagnosis. Yeah.
Well, thank you. Let's move on to the next speaker then.